Welcome to the podcast.
All right.
Pilates for PTs, from business to clinical. Hi y'all, my name is Stephen Dunn. I co-own Core Therapy and Pilates in Austin, Texas, and I'm the founder of Pilates for PTs. I've been a physical therapist for over 20 years, and I've been teaching Pilates and gyrotonic in my physical therapy practice for the last 15 years. In this podcast, I interview experts from all over the world so that you can learn more on how to grow your business or how to improve your clinical skills as a Pilates instructor in the physical therapy world. Thanks for listening.
Perfect.
So what's up, guys? Hey, it's Stephen Dunn here from Core Therapy and Pilates, and I'm here with my brother, Dr. James Dunn. He's in from Northern California, and he's a urogynecologist. So we're going live today on my business Facebook page. We're also going live down here on our marketing page. So we're going to be looking up here, but we want both groups to hear this message. This message down here for the marketing group, this has nothing to do with marketing. This is going to be clinical, but everyone here working with personal training that typically has questions about pelvic floor health and things like that. So I think it's going to be very applicable to this group. But to the group up here, my business page, we get so many questions in the clinic on a daily basis about pelvic floor strengthening, about Kegels, about all these things that come into play whenever we're working with back pain. A lot of back pain is contributed to weakness in the core, weakness in the abdominals, weakness in the multifidus, but also weakness in the pelvic floor. So what I wanted to do today is have Dr. Dunn go over a little bit of, first of all, what is a urogynecologist? Because that's a question I get a lot whenever I discuss what he does. And then a little bit of some, I'm going to ask him a few questions to kind of see if my audience can get some helpful information out of this. So first of all, Jamie, Dr. Dunn, tell me a little about what is a urogynecologist.
I get asked the same question, and I've been doing this for a long time, but a lot of confusion. I started off as an OBGYN doctor and did 4 years of residency, but then went back for 3 years of additional training in pelvic floor therapy, conditions like urinary incontinence, fecal incontinence, pelvic prolapse. So primarily female urology with a special interest in pelvic floor anatomy and pelvic floor surgery.
And a way I kind of explain it when people ask me questions about like, well, should I see my OBGYN or should I see a urogynecologist? What I explain is, well, if you've ever had your wisdom teeth pulled, you can have your wisdom teeth pulled by a dentist. But if you go to an oral surgeon, he's a little more versed and trained, and he does more of it. And
Correct.
So you could go see a regular OBGYN to do most of what you do, correct, but that's not what they do all the time, correct?
Yeah. My 75% of my practice is exclusive pelvic floor therapy and pelvic floor problems.
Do you do any OB at this time?
I do not deliver babies anymore.
Gotcha. That's what I thought. So there's the kind of the differences between the two. Now, anyone that comes on, I see we've got a few people joined in. Just if you have any comments, put them below, and we'll make sure to answer your questions. So my first question is can you tell us a little bit about urinary incontinence, stress incontinence, as far as how frequent it is, and a little bit about how you treat it?
For sure. It's the number one consult that I get is urinary incontinence. And then urinary incontinence is a broad category with multiple types. And that is what we try to do with their first consult is figure out and tease out. Is it stress incontinence with coughing and laughing and sneezing and exertion?
Jumping is what we hear.
Jumping and trampolining. I hear all of those questions like that. And then the other type of incontinence that's not as common but still very prevalent is overactive bladder, which is a syndrome of urinary urgency, urinary frequency, and getting up at night too many times. So those are the two most common. And then there's another group that has a little bit of both of those types, and we call that mixed urinary incontinence. And so that's kind of sums up the majority of the incontinence that I treat. As far as treatment and options, that's another whole topic. We could talk about that for an hour, but I'll give you the fast consultation.
The Cliff Notes.
The Cliff Notes. So
Do they still make Cliff Notes? I don't even know if they still make Cliff Notes, but they sure made them when I was a kid.
English, yeah. I did not like English, so that's why I went to med school. So for stress incontinence, and for overactive bladder, the best treatment is going to be your pelvic floor therapies and what I call behavior and lifestyle modifications incorporated with pelvic floor therapy. Having women practice their Kegels, and more importantly, teaching them how to do the Kegel exercises correctly. We've been able to see that there's probably 20 or 30% of women that don't know how to isolate their muscles, and so they need extra training. There's medications for overactive bladder. There is some neurostimulation therapies out there that stimulate the pelvic floor and the sacral plexus. Botox is my new favorite treatment for overactive bladder. It doesn't help with stress incontinence. I do a lot of Botox injections there in the office with the cystoscope. And then last resort for stress incontinence is the surgical things that I do, the slings and injections. But like I mentioned, I try to get everyone to work on behavior and lifestyle changes in pelvic floor as my go-to for women with incontinence.
Now, you mentioned the last step being a surgical intervention. Can you talk a little bit about the program that you've run and the success that you've had with people that, I can't remember the number, but it was over 80% of people that are not having to have surgery because of the program that you're taking them through. Can you talk about that for a second?
Yeah, yeah, definitely, because that's my go-to, because it actually treats both types of incontinence. So it treats overactive bladder, which is sometimes called urgency incontinence, and it treats stress urinary incontinence. And I just call it pelvic floor therapy. It's a comprehensive program with my nurse or my nurse practitioner, and you come in for weekly visits, about 30 to 40 minutes per week per visit. We do about 6 to 8 visits to get the maximum benefit. And as you mentioned, about 70-80% plus of patients are getting significant benefit and are able to avoid surgery and are able to avoid taking medications. In the program, it's a combination, excuse me, of behavior changes, meaning how much do you drink and how often do you go to the bathroom, and of course teaching and reinforcing the pelvic floor exercises. We have biofeedback to help women isolate their pelvic floor muscles stronger and better, and then we do use an electrical stimulation protocol to kind of basically overstimulate the pelvic floor to help regenerate muscles and nerves and get the pelvic floor working like it's supposed to.
Do these women learn a program to do at home in between those visits, in between those weekly visits?
Right, yeah. So that they definitely get homework, and we call it homework because if you don't do the homework, you're not going to learn the lifelong things that you need to do, the rest of your life as far as to maintain the pelvic floor. Most of the women have had children 20 years ago, 30 years ago, and completely forgot about their pelvic floor strength. And we always joke and say, use it or lose it. And we're trying to help them rebuild it and relearn it. And then we also have a home device that is available that women will sometimes use if they don't want to keep doing the program on an ongoing basis, which works great. So
that's like a portable E-stim type of unit?
Yeah. It's a vaginal probe with the electrical stimulation protocol.
Gotcha. Well, it's interesting. As a PT who specializes in back pain and Pilates, we specialize in Pilates. A lot of my clients come in with back pain, and they don't tell me about the stress incontinence or those things. They just tell me about the pain and the things they can't do because of the pain. And then typically when we take them through the program, on our program being some hands-on manual therapy and Pilates and gyrotonic training, once we take them through the program, a lot of times 2 months, 3 months later, they say, well, I'm no longer having these issues with stress incontinence. Even though they didn't tell me that at the beginning, we're re-educating the pelvic floor and teaching core work with everything we're doing. And what he said is that lifestyle change. And if you go in and do something 30 or 40 minutes or an hour a week and you don't make it a part of your life the rest of the time, it's kind of pointless. It doesn't seem to carry over. Right. And so, we teach homework to all of our clients, and the clients that do really well are the ones that do the homework, and the clients that don't do so well, they don't really, they expect us to fix them. And if people can take a little bit of ownership in this process, which it sounds like you're allowing people to empower themselves through the process before they have surgery. And by the way, this is a surgeon giving people all of these opportunities to avoid surgery. So that's one of the coolest things that when him and I chat about this, and never did I realize when we ended up in our own fields that our fields would kind of be so similar, and we would be able to have these kind of conversations. But I now know that all of my clients, I shouldn't say all, but a lot of my clients have pelvic floor issues because we specialize in treating women that are 45 and above. And again, they've had babies 10 years, 20 years ago. So now the last thing, we're going to wrap this up, but I want you to just go over a little bit of anatomy. I get asked about the pelvic floor anatomy frequently, and I just kind of reference it as a sling underneath the pelvis. And I don't get into any more detail than that because it kind of confuses people. But I wanted you to just briefly go over the anatomy, and this will be the last question, unless we get any questions that come up on the board. But just kind of go over the anatomy, and then we'll wrap it up here in a moment.
Yeah, the main thing of the pelvic floor is you have the bony parameters of the pelvis, and they're not going to change because this is fixed. But the pelvic floor muscles basically act like I call it a bowl, and so it's a pelvic floor bowl. Of course, the bladder, the urethra, the vagina, the GYN, uterus, and pelvic and organs are there, and of course the rectum and the anus. So you have three very important functions coming through the pelvic floor in a tight space, and that's why they say, when you have dysfunction of one, you can have dysfunction of all three. So it's a tricky thing. But think of the levator plate. It's called the levator ani. It has three muscles. They all have a bunch of long names, so I'm going to just call it the levator ani plate, and because it's a lot to memorize.
It's a mouthful,
and it's too much. It's like just you want the big picture. The big picture is everything sits on the pelvic floor. It has tonic strength that just is resting and holding, but more importantly for incontinence is that quick squeeze that the pelvic floor does to hold urine and to keep women from not having urinary or fecal incontinence. And so, it's very interesting how it has to have the support, but it also has to have the function to hold our daily activities, our urination, defecation, and obviously sexual response. So it's and of course it's innervated by the pudendal nerve, which comes off of the sacrum 2, 3, and 4. It's called the sacral plexus, and so the pudendal nerve, you'll hear that a lot, innervates the levators and gives its strength.
And we see a lot of people with L5, S1 nerve issues, with sciatica issues and things like that. So that's just a little further down the chain. So the sacral nerves are coming out down through here in the sacrum, right through these little holes. You can see them right there. Versus a lot of what I deal with back pain is nerve problems from the disc that are coming right here as the lumbar are stacked up. So, yeah, for sure. All right. Well, that's all we got for you guys today. We're going to be putting together some more information moving forward. We're going to put together basically that little program that he does. We're going to make a course out of it and have available in the next few months. So we just wanted to kind of come on, discuss a little bit of information. And anyone has questions, reach out to us through the Facebook group. Reach out to us through the Facebook page, and we'll be putting some more information out about pelvic floor health because again, we see how important it is on a day-to-day basis with all the folks that we treat. So, and we did one of these discussions. It's been several months ago, and we talked about pelvic floor health, and we talked about some the programs that Jamie does, Dr. Dunn does for his pelvic floor patients. And we talked a little bit about the difference between what is a urogynecologist and what is the difference between seeing a urogynecologist and a regular OBGYN for the kind of surgeries that he does. And my reference or my discussion was I like to compare it to a dentist and an oral surgeon. You can get your dentist to pull your wisdom teeth, or you can get an oral surgeon to pull your wisdom teeth. Both of them can do the job. It's just one of them does a lot more than the other. And one of them would be more of an expert of the surgical part, and one would be more of an expert of the other things. And so I think that's a real simple way to talk about it. Now, if anyone has any comments, put them below, and we'll be happy to answer any questions. But what I wanted to do was just continue the conversation, because something that is that I find is of importance, or that I find is we're at a place now where it's okay for women to basically have urinary incontinence. There seems to be the push, the message from the watching TV. It's all about medications, or it's all about diapers. Wear diapers, adult diapers. And I think there's a different way of approaching things other than just spending money on adult diapers. And I can't remember the figure, but the amount of money spent on adult diapers, billions, versus actually trying to get it taken care of, way less on a yearly basis. Yes. So with that said, thanks for being here, Dr. Dunn.
Yes, wonderful Thanksgiving.
And yeah, we got to spend some time for Thanksgiving, and he's leaving today, so I took advantage. I was like, hey, give me 10 minutes and let's go through some stuff. So my first question to you is if a woman is having, when is the right time for a woman to come see you?
Yeah, probably. I mean, I get consults all the time. Ignore that. With more advanced problems, moderate and severe problems in older women, but I think the best time is 30s and 40s after childbirth. Definitely start on some kind, pelvic floor therapy on their own. If the symptoms progress or don't respond to simple Kegel exercises and pelvic floor training at home, weighted cones, vaginal weights, things like that you can do on your own, then yeah, physical therapy, more aggressive treatments. But I would start right after childbearing.
So basically, is it normal to be having any urinary incontinence?
It's not normal. It's just
it's common.
It's common. So it's a common thing. It's not like I get that question a lot. It's just a common consequence of childbirth and pregnancy. Is the number one risk, so especially vaginal deliveries. You get some protection from cesarean sections, but pregnancy itself is the number one risk factor.
And if someone comes in with urinary incontinence, the treatment plan doesn't start with surgical intervention. It starts with other stuff first, correct?
Very rarely does someone come in and already made up their mind. They're like, I want surgery because of whatever they've heard or read, or my friend had surgery and I want that surgery. Most women come in and say, yes, I prefer conservative, non-surgical medications if there are, therapy. So, yeah.
And then if someone goes through the conservative treatment, they do the Kegels, pelvic floor strengthening. They do the possible probes and E-stim training.
Correct.
What kind of what's the numbers of people, the percentage of people that go through that program and then end up needing to have surgery?
So we'll go to the positive, about 70 to 80% improve or significantly get better where they don't need surgical therapy or other therapy. So that leaves about probably 15 or 20% of women who do need surgery or fail conservative options.
And let me ask you this: you and I have had this conversation. If you watch the TV, you see all these lawyers advertising if you've had mesh surgeries to call them for this and that. So I think there's been some maybe misinformation or some bad information out on these mesh products, where I have people ask me questions about the mesh because they've seen the lawyers advertising.
Right.
And that's something that I don't really understand or know. But you mentioned to me that if you were concerned about the mesh, that no surgeries would be happening. It's kind of what we talked about. It's been several months ago,
Yeah.
but with the mesh and the kind of fear factor out there of if you get this incontinence surgery and they're using this certain mesh, that there's going to be a long-term problem or a lawsuit after. Tell me a little bit about that.
Well, the mesh surgeries are definitely there. They have mesh surgeries and they have non-mesh surgeries that I offer, and we have that long discussion as far as the consent process. Do you want this with these risks and benefits in this surgery? The main concern with the lawyer ads is based on the pelvic surgery with mesh. It does have a higher complication. I haven't been doing that mesh surgery. I still do the sling surgeries, but with a longer discussion and say, yes, every surgery has risk. The mesh surgery has some specific risks only related to the mesh, and so you just have to say, the risk are 90% plus for success, and a couple percent chance of those things you see on TV, and then you go from there.
Got it.
After that process.
Got it. Well, these are just some things that questions that I get, questions that I don't always know the answers to, and so while you were here, I wanted to go through and ask a few questions. It doesn't look, we've got a few people that have jumped in. Hey, Jared, what's happening, buddy? We don't have any questions that have popped up. So let me finish with this one. If someone goes through the procedure, or they go through the surgical procedure for a sling, for example, what kind of recovery is after that, and how long before they're able to do normal exercise, and how long are they, when should they start doing Kegels?
Probably right after surgery, start your Kegel therapy, because that doesn't disrupt or injure, complicate the recovery. For after the surgeries, I typically do a combination of pelvic surgery, like bladder lifts and sling surgery. So I ask those ladies to go slow for 6 weeks.
Mm-hmm.
Not do nothing. I want them to get their cardiovascular fitness so they can walk and treadmill and swim and do light. I just ask them not to lift anything heavy.
And low impact.
Low impact. We made the number up 20 pounds. Don't lift more than 20 pounds, but we don't have a study that says yes or no. So I tell them, be moving, but just be mindful of how much pressure you put on the pelvic floor.
Got it. Because that's a question that I get, and usually by the time they're coming to see me after surgeries, it's been more than those 6 weeks, just based on the whole process. But that's a question that I've gotten, and 6 weeks is kind of a safe zone for many things in medicine. Bones, fractures heal in 6 weeks. A lot of stuff happened in about 6 weeks, so that's typically a safe answer, but I just wanted to get your clarification of that. All right, guys, so with that said, we are done for the day. Hey, Andy, what's happening, buddy? So if you have any questions, if you're watching it later on the replay, put some questions down below, and we'll be happy to answer them. But I got Jamie in town for the rest of the day, and I wanted to take advantage of sharing some information that can be useful to our clientele. So with that said, thanks for your time. Thanks for your time, Jamie, and thanks for your time for watching. And we'll see y'all on the flip side, guys. Now he's got a Pilates class.
Pilates.
Peace, guys. Well, I hope you enjoyed the podcast, and if you did, could you do us a favor and leave some love and write us a review? My name is Stephen Dunn. I help physical therapists incorporate Pilates into their physical therapy practice. If you would like more information on how you can incorporate Pilates into your physical therapy practice, then like my Facebook page, Pilates for PTs.